All right, ladies and gentlemen, let's try to get started. It's lovely hearing everybody chatting away, so it almost feels bad to interrupt, but we need to get started. There are many exciting sessions, and I know there's one at 14 hours on South Africa's health insurance, which I want to go to, and probably some other people as well. So we will try to finish a bit early. Is that echoing sound? So welcome. Today we are here to talk about the experiences of implementing health insurance in Zambia. Maybe we can get the slides up. And we have a great group of people who is going to help us do that. But first I wanted to kick us off a little bit in the sense of talking about, why do we have health insurance in Zambia? Why are we actually working on health insurance in Zambia? Well, the obvious answer is that it's one of the steps in Zambia's ambition to achieve or move towards universal health coverage. Those who were in the session earlier this morning, we learned that UHC is not a destination, it's a direction in which we're traveling. And Zambia is moving in that direction. But then what is UHC? And I want to spend a couple of minutes just to get us on the same page. For those of you who run to these meetings with the WHO, you often get that cube. I show that cube when we teach about universal health coverage at universities as well, and people nod, but nobody really understands what it's all about. But we pretend we do. So I try to simplify it, and I say that UHC is about people, it's about money, and it's about health services. And when we talk universal, of course, we talk about everybody. So people is basically everybody, right? But then we talk about services and money. And that's really much of the focus today. We have the money that we have at any given point in time. And what can we actually offer to the entire population with that pool of money? And at the end of the day, that's what we're trying to do when we talk about universal health coverage. But the health insurance in Zambia is not, the first step towards universal health coverage in Zambia. It started already back in 2006, you can argue. There was a removal of user fees. It's very popular at the time to remove user fees, and they did that first in the rural areas. Subsequently, they moved on to removing user fees for primary care in urban areas, developing a national health financing policy, developing a basic healthcare package. And then in 2018, the bill was passed on health insurance and subsequently started implementing in 2019. So all these steps are, moving towards universal health coverage in Zambia. But where are we in 2023? I think that's what we're primarily focusing on today. And we are glad to have people here who can probably help us think about, reflect on the challenges, also the opportunities ahead. But we have first a set of presentations where we'll go through a bit of background and also from the experiences. So first we have Joseph Kazibwe from Lund University, who will be presenting results from a systematic review of evidence on impact of health insurance. So then looking at other countries' experiences of health insurance. That will be followed by Herriman Muno, who is the research director for the National Health Insurance Management Authority, NIMA. And he will then reflect on the implementation that's been going on over the last 3.5 or so years. Followed by that, we have Warren Simangolwa from UKZN, who will talk about stakeholder perceptions of the insurance, both looking at the public, but also the private sector providers. So the general public and the private sector providers. And finally, Felix Massier was supposed to talk about evaluation, but unfortunately Felix couldn't make it, so I will talk about that. So it will be a stand-in doing his best to talk about evaluation of it. That's the outline for the first part of this session, and then we'll move over to a distinguished panel who will help us reflect on what we learned. So with that said, I'm going to hand over to the first presenter of the day, who is Joseph Kazibwe. Joseph.
Thank you. Sorry. Thank you so much, Jesper. Sorry. Thank you so much, everyone. And it is nice to see that the room is almost full. So thank you for your time and prioritizing to attend this session. So I'm Joseph Kazibwe, and I'll be sharing some bit of evidence that actually looks at the impact of health insurance in low and lower middle income countries, taking the maternal and reproductive health perspective. So this is a systematic review that was recently carried out. Going back to UHC, many countries are aiming for this. UHC, as already described by Jesper, but actually when you look at the map that shows the coverage index, some countries are really lagging behind. So majority of the countries are below 70% of the coverage. And majority of those countries below 70% are low and lower middle income countries. So lower middle income countries, among other countries, are trying to look at reforms that could propel their advancement towards universal health coverage. And some of those reforms that they're looking at involve financial all health financing reforms. For example, starting up insurance schemes. So when you look at UHC, it has 4 major components, of which maternal and reproductive health is one of the 4 major components. And in maternal and reproductive health, we look at contraception, antenatal care, and then delivery care and postnatal care. So for this study, we considered all the 4 aspects of care for maternal and reproductive health services. So in terms of the aim of this study that I'm going to share, all that I'm sharing about, so we aimed to assess the existing evidence on the impact of health insurance on maternal and reproductive health services utilization and financial protection in low and lower middle income countries in order to inform the ongoing discussions on which reform maybe a country should take up. So we used the systematic review approach and then also followed the PRISMA guidelines in reporting of the review. And the period we covered is evidence published after 2010 until recently, which was May 2023. And we incorporated 6 databases, including Web of Science, Medline, Embase, Scopus, and Econlit Complete, and then also Cochrane. So we did an assessment of the quality of evidence. And as you will know, later in the presentation, there was a lot of available evidence, but very few studies actually are of quality, and very few studies actually look at impact in itself. So we used the Robson 1 tool for assessing the quality of the studies. So we, having searched the databases, so we found 11,988 studies after removing the duplicates, and then screened these. Only 17 studies actually fulfilled our inclusion criteria, which actually included including studies that look at impact of health insurance. And the insurance that we are looking at is public insurance, all public not-for-profit insurance. So this includes community-based health insurance, and then also social health insurance, and also publicly funded insurances. Categorization of insurance is debatable, and also names can be deceptive sometimes. So we look at the actual way the scheme is implemented. So in terms of study characteristics, majority of the studies, so we are from Ghana and Indonesia, just 3 studies of the 17 studies. And then we had other countries like Philippines and Mauritania having 2 studies each, and countries like Tanzania, Egypt, Rwanda, Ethiopia had only 1 study, and also there was a study that had 3 countries in 1. So in terms of participants, majority of the studies looked at women of reproductive age, that is 15 to 49. And no study actually randomized the treatment. So in other words, we didn't have any clinical trials or any trials in this particular case. But so we did have studies that controlled sort of like intervention control groups. And therefore, majority of the studies, which is all the studies, were quasi-experimental studies. So we excluded studies that were cross-sectional and non-experimental, or didn't have any control groups. So in terms of quality of evidence, as regards the 7 dimensions of bias, so we found that 3 studies had serious risk of bias, and overall quality of evidence, which is gauged by the grade criteria. So those 3 studies were excluded in the descriptive reporting of the impact. So the indicators that were used by these studies included contraceptive use. So we categorize the indicators according to the type of care, maternal health, maternal and reproductive health care received. So we had contraception, antenatal care, delivery care, and postnatal care. And when you look at contraception, so majority of the studies that reported on contraception were reporting on contraceptive use, all modern contraception methods used. So without necessarily specifying at what point, before the pregnancy or after the pregnancy, that wasn't specified. The same applies to postnatal care. They didn't specify the timelines for receiving postnatal care, but they just elicited whether someone had received postnatal care or not. Then the majority of the studies reported actually on delivery care and antenatal care. So with delivery at health facility being the most reported indicator. So in terms of impact, so we find that there was plenty of positive studies reporting on positive significant results in delivery at health facilities, and then also delivery with skilled birth attendants. So delivery care, I think, was mostly positively impacted by insurance compared to other forms of care received by the mothers or prospective mothers. And for the frequency of antenatal care, so at least 4, having at least 4 ANC visits was also sort of like an indicator that was positively impacted by insurance. However, when you look at financial protection and contraception and postnatal care, the results were sort of like inconclusive, in addition to being scarce. So there was scanty of available evidence. So we had, we explored doing a meta-analysis on the results, and the results were sort of like reflective of what we actually found descriptively. But we left the meta-analysis out because of heterogeneity that exists within countries and between countries. So overall, just to summarize, so health insurance shows narrative law descriptively a positive impact on utilization of ANC and delivery care. However, when you look at the overall available evidence, so there is a scarcity of evidence on financial protection of the mothers, and then also contraception and postnatal care. So there are certain questions that still linger around, which include equity. Yes, we are seeing that maybe people are delivering more in hospitals due to health insurance, but actually, which kind of people are they? Are they from a given quintile or income class or socioeconomic status? So that is some question that needs to be answered. And then also in terms of financial protection, why is it actually that we are not reporting much about the impact of health insurance on the financial protection of mothers, all of families that are having deliveries, all are accessing maternal and reproductive health services. So I think as this discussion goes on, it will be interesting to understand how the Zambian experience is like as regards the impact of health insurance on maternal and reproductive health services and also other services within the country and financial protection. Thank you so much.
Thank you, Joseph. That's great. So we were quite surprised. First we had 60+ articles, if you go by impact, in terms of somebody describing impact themselves, but applying much more stringent inclusion criteria, some sort of quasi-experimental method, or being able to claim some degree of causality. We ended up with only 17 studies, and then extremely limited evidence related to financial protection. So that's just to set the font for this. Now we'll move over from a very research-like presentation to a bit more sharing practical experiences. And for that, I will hand over to, there's something magical about this. If you put it down, it stops. What can I do to reactivate it, sir? There we go. We'll hand over to Mr. Herriman Muno, who is then the research director of NIMA. Welcome up, Herriman.
Thank you.
Yeah. Okay, great.
Yeah, thank you so much. So I'll speak briefly about the experience from implementing the scheme. Of course, we have a few lessons that are important for the research aspect, but also a few lessons that we learned from the research aspect as well. So as you may be aware, this is one of the latest schemes, mandatory schemes in Africa, which was started in 2019. The Nhi Act, the National Health Insurance Act, was passed in 2018, but the actual implementation began in October 2019. So it's a relatively young scheme, but quite a lot of lessons that we have picked up, which we hope we share. So that's the structure. As I mentioned earlier, the scheme began in 2018 as a health financing mechanism to complement general tax revenue. There was a realization that the current mechanism we had then was not raising sufficient revenues to cover the needs of the population. And as a vehicle for achieving universal health coverage, the National Health Insurance Scheme was put in place. And of course, this was aimed at, among others, one, providing financial risk protection by reducing catastrophic and impoverishing expenditure. That is really looking at the demand side of healthcare. So you enhance access to healthcare services by reducing the financial barriers, but also ensuring that the availability of funds are enhanced. That is on the supply side of healthcare. But also importantly, the issue of equity, access to health. So reducing the equity barriers and the inequality that existed prior to the introduction of the scheme. And as you see slightly later, prior to 2018, 2019, only about 5% of the population had any form of insurance. The rest of the population had to rely on either out-of-pocket payments or did not actually access healthcare services at all. So there was quite high levels of inequality. But also, we saw this as a way of enhancing private sector participation in the healthcare system. By bringing both public and private healthcare providers under the scheme, you enhance potential competition and therefore increasing quality of services. And then ultimately, seeing this as a vehicle for achieving universal health coverage. This is what the implementation timeline looked like. As I mentioned earlier, before 2018, only about 4% actually of the population had any form of health insurance. Primary health care, as Jesper earlier mentioned, was free. User fees were removed by 2006. Then we had the voluntary schemes, the private voluntary schemes. And then, of course, there were discussions around the feasibility of starting the scheme. The first actuarial evaluation to assess the feasibility of the scheme was done in 2008, but the political processes could not allow its implementation. We had a second actuarial evaluation done in 2012, and after that, there was momentum which picked up to push the agenda for the scheme to start. April 2018, the Nhi Act was implemented, Act number 2 of 2018. Then, of course, 2019, September, a year later, the statutory instrument was signed to begin the actual implementation of the scheme. And then, of course, there we are today. We've seen quite a lot of changes, a lot of lessons that we're going to share. So just basic key structures and key features of the scheme. It is mandatory in nature. So all the formerly employed have to contribute to the scheme, and you contribute based on your ability to pay, but you access services based on your need. So what you see is that the contributions are not directly commensurate with the benefits that you get. Now, that is good for universal health coverage, but it has a potential challenge with regards to the solvency of the fund. And then, of course, the aim is to achieve universal health coverage. So all access the services they need, right? And it's comprehensive. So because it's a national scheme, the benefit package is probably one of the most generous packages you will ever see in the world, given the levels of contribution that we have. And of course, we want to achieve financial risk protection. So at the point of accessing healthcare services, you do not pay out of pocket at all. So it's cashless access to services. And then we run a single fund and a single payer. Right? So we collect the funds, we have a national health insurance fund, and from that fund, we pay for services both to public and private healthcare providers. So we're a strategic purchaser in some way because we accredit facilities based on the need that we need in terms of the services that we need, but we also have the power to negotiate prices. So we don't take the prices as given. We decide the price at which we buy. And because of that, we're able to contain the prices. And then, of course, like I mentioned, we have multiple healthcare providers, both public and private. Of course, as earlier mentioned, this is based on the principle of social solidarity, and it's all about redistribution to reduce inequality in access to healthcare services, and importantly, contributions based on ability to pay, but access is based on need. Now, the ability to pay here can be zero for those that do not have any form of income, but therefore, of course, they'll have a need. And that is a good thing for UHC, but as you will see later on, it's a potential challenge for the solvency of the fund. Okay, so what is the structure in terms of the implementation model? So you have, we're on this side here, the National Health Insurance Management Authority that manages the fund and accredits healthcare providers. These will be public and private healthcare providers. We expect that as a national scheme, we'll get appropriation from the central government to finance any deficit that we might have. And then, of course, we accredit healthcare providers there. Primary healthcare services are provided free of charge by the central government, so we don't take care of that. We kick in at the curative level of care. So this is level 1, level 2, level 3 healthcare providers. And this is where you expect high levels of out-of-pocket spending to be because primary healthcare services are taken care of. So the citizens will pay premiums to the authority, and based on their premiums and based on their registration and payment of premiums, they will access healthcare services in a cashless manner, and the healthcare providers will invoice the authority and will pay for those claims. So there is no money transmitted between the citizens and the healthcare providers. Everything is done between the authority and the healthcare providers. So what have we picked up so far? How has things been since the scheme began in October 2019? So far, this is as of earlier this year, so far we have registered 3.4 million members on the scheme, which represents about 17% of the population. But the bulk of this population is actually from the formal sector. Remember, the scheme is a contributory scheme, so contributions are based on one's payment to the scheme. So basically, almost the entire formal sector is well captured. We're quite okay there, but we've also begun extension of coverage to the informal sector. So those are the principal members and the beneficiaries, and that's been the trend in terms of registration over time. And then, of course, the distribution of members by sector. What you see is that in terms of informal sector cover, we are probably one of the biggest social security schemes in Zambia that has high coverage of the informal sector. That is expected due to the nature of the service we are offering. So people are more likely to contribute to health insurance than to pensions, for example, because the benefit is immediate. But as you see later on, we have a bit of challenge with adverse selection with the informal sector, which jeopardizes the solvency of the fund. So currently we have over 355 healthcare providers, both public and private, and that's really how the trend has been. Now, in terms of the accredited HCPs, those are the healthcare providers. When the scheme started in 2019, it only had public healthcare providers. The idea was that we'll progressively move to the private sector to complement the services rather than to create competition between the two. But also there was a bit of anxiety from the private sector to participate in the scheme. They were not sure that this would actually survive. So we opened up accreditation in January 2021, right? And what you see is that there was a sharp rise in accreditation from the private sector when they saw that actually they can make money from the scheme, right? So we now have more private healthcare providers than public healthcare providers because of the profit incentive that the scheme has created, which is good, but also comes with its own challenges in terms of solvency of the fund. And here is just to show you the variation with regards to contributions and claims over time. What you see is that from the time that the private healthcare providers came in, so did the rise in claims, unexpectedly so. And we'll talk about some of the challenges we have faced from that. So that's where we are right now. And what you have here is just exactly what I shared earlier. The private firms came in and you saw a rise in accreditation. We have the provincial distribution of the facilities there, and then also have the type of facilities. Of course, expectedly, most of them would be the hospitals, the pharmacies, and the optical centers, and all the other services which reflect the benefit package of the scheme. So, notwithstanding that, we still face quite a lot of challenges. And I think this is really the biggest experience we can share here. The low formal sector, the size of the formal sector in Zambia presents its own challenges. So currently, only about 17% of economic activity is in the formal sector. So meaning that we are constrained in terms of raising revenues because we have that formal sector, which is limited. But also the contributory rate from the formal sector was set at the lowest minimum at 2%. 2% split 1% employer, 1% employee. This was a political reason to create buy-in from all the stakeholders, right? And the idea was, let's start low, we show value over time, and hopefully can increase the contributory rate, right? And that is proving to be a bit of a challenge. The ideal contributory rate that the actuary had determined was 5% if the scheme was to be sustainable over time. But the politics kicked in. 5% moving towards a political election was going to be suicide. So they settled for 2%, 1% employer, 1% employee. But then you settle for 2% with an enlarged benefit package, right? And that poses challenges in implementation. Of course, high informal sector activity restricts enhancing of coverage, right? With the informal sector, because we cannot collect revenues at source, we rely on voluntary compliance. Now, what we are seeing is high adverse selection. People come onto the scheme when they are sick. Now, because contributions are based on the ability to pay and access based on the need, they'll contribute lower premiums, but access high costly services, which jeopardizes the solvency of the fund. Then, of course, the typical challenges of high poverty levels. With high poverty levels comes high levels of utilization and high dependence as well. And what we saw, the big one, is demand shifting from the public sector to the private sector when you brought in the private sector. There is this perception that there is high quality of care in the private sector compared to the public sector. Now, for us to attract the private sector, we had to have higher tariffs compared to the public sector. So for any demand that comes to the private sector, the reimbursement is higher compared to the public sector. Now, we open up the private sector and the demand shift to the private sector at a higher tariff that claims the private sector extremely high. So of course, that has resulted in limited collections, limited extension of coverage in the informal sector, limited coverage for the poor and vulnerable who have zero or little contributor capacity, and of course, high utilization of private healthcare providers, which is costlier than the public sector. So we conducted our first client satisfaction survey last year to see what people are saying with regards to the implementation of the scheme. And these are really the key results that you get. What is interesting is that the biggest complaint is on service delivery. So now we as a scheme do not provide services, we pay for services, but the complaint about the scheme is on service delivery, especially public health service delivery. That speaks to the need for enhanced preparation for any public scheme, any service providers on the public sector before the scheme comes in. What we're seeing is we should have perhaps enhanced investment in the quality of services before you introduce the scheme. Because now the services that are not being offered in the facilities, the low quality services that are being offered in the facilities, the complaint is not to the facility, which is the healthcare provider, but it's coming to the payer. right? So we are now facing the heat for the challenges that the healthcare providers are supposed to be addressing. So what are the key lessons that we have picked up from the 3 years? First is high political will is critical. Without political will, the scheme would not have started, right? But you need the right political will. We started on a compromise note with regards to the contributory rate. The will was great, but it was a bit compromised because you had to have buy-in. But just as political will is critical for start, it's actually important to sustain the scheme. When people have access to benefit and enjoy the benefit, it's difficult to take it away from them. So you need higher political will to sustain the scheme. There is a need to enhance in service readiness and availability for the public sector, especially the public sector, before the scheme comes into place. Otherwise, you face the risk of diverting demand to the costlier private sector and reducing the satisfaction of members. The benefit package design must be influenced by the financing mechanisms, by financing feasibility. We have a generous benefit package that does not reflect the feasibility of financing, right? And I think from the lesson is, let's ensure that what we design in the benefit package reflects what we can pay for, otherwise you run into deficit. Then of course, there is need to deliberately and positively discriminate towards the public sector so that you can enhance the quality of care. Like I said, the members do not distinguish between financing and service provision. They see the poor service delivery as the problem of the financier, right? And so it means that we have to work closely with the providers themselves to ensure that the member has a high quality experience. Then of course, what we've picked up from the private sector is your typical case of provider-induced demand or supply-induced demand. The private sector is driven by profit, and they will take any advantage to maximize profit. So we have to be very careful when we design such schemes to ensure that we do not create incentives for provider-induced demand. Then of course, the informal sector remains a big challenge. So at inception, you have to put in measures that will address the issue of adverse selection. What we are seeing from the scheme is that the biggest potential driver of the deficit is actually coming from the informal sector, because they self-select into the scheme when they are sick. And we're a public scheme that wants to achieve UHC. You cannot stop them from coming onto the scheme, but there have to be measures and incentives that ensure compliance throughout the membership of the scheme. So briefly, those are the key lessons that we have picked up. Thank you.
Thank you so much, Herriman. No, please stay. Please stay for a second. There might be questions for clarification. There's one from online. Thank you for posting questions online. I'll start with that one as people in the room think, and don't have lengthy questions or comments. We'll have more time for that, but maybe more for clarification. So how did the Insurance Management Agency access initial investment?
Sorry?
How did the insurance agency access initial investment before you had started collecting funds to get it off the ground?
Okay, right. Great, thank you. So ideally, you'd have expected an initial investment from the central government. That was the expectation, but that didn't happen. What we had was that we created what we call a waiting period. So although the scheme began collections in October 2019, access only opened up on 1st February 2020. So I had a 4-month waiting period in which we grew a fund, then allowed access to only public healthcare providers. Also, that was deliberate because we knew that we're not paying the full price of access to the public. So you have a 4-month waiting period before one can access the services.
Yeah, thank you very much. I think that's the benefit of sitting in front. All right, thanks for your presentation. I think this is really, really revealing. The question for me, though, is when it comes to the, so you said 2%, is it 2% of the gross salary?
Basic.
Right. And if so, is there also a co-payment somehow during the access to healthcare at the facility level? Maybe that's a question. But is there a way to also regulate? Do you have maybe a referral mechanism? How is that also put in place or structured? Can you clarify that?
Sure, thank you. So it's 2% of basic income. Like I mentioned earlier, it was a compromise. It was a political compromise. Ideally, you'd expect 2% of total taxable income, but this was 2% of basic income. And with that, what we're seeing, especially from the private sector firms, is that there's, a creative accounting where they are taking away the benefits outside the basic income so that their liabilities are reduced. Ideally, we should be collecting 2% of total taxable income. And those are the discussions that are currently happening, but also that is in line with the best practice in social security. So if you look at the tax regime and the pension regime, they're all living on total taxable income. We are living on basic income. Yes, in terms of the referral system, so as I mentioned, we only kick in when you get to the curative level of care, right? So these are the level 1, level 2, level 3 hospitals. So by that time, you'd have passed through the referral system. If you bypass the referral system, the hospitals themselves have a penalty mechanism that takes care of that.
Thank you, Chair. I'll just ask a clarification question, but I have a number of questions that I can always discuss later. One of the things that I'm interested in, you said quality of care was an issue, especially in the public sector.
Yes.
Can you say something a little bit around the accreditation criteria?
Sure.
Because I would imagine the accreditation criteria applied to the private sector is the same one that is applied to the public sector. So therefore, why are we where we are, where then the public sector has some challenges? Thank you.
Thank you. Well, the issue of accreditation is an interesting one. I think the Director General will speak to that a little bit. So with regards to the public sector, we take it as a given, right? We're a public scheme, so we run with what is currently running with government. So we would not certainly penalize per se the public sector because they are the ones who are providing the most care. But we expect higher levels of care from the private sector because we're paying a higher premium than we're paying to the public sector. Now, of course, the quality concerns are not addressed by ourselves. We have what we call the Health Professionals Council of Zambia. So the standards are set by the Health Professionals Council and we work with those standards. But we expect a little bit higher quality from the private sector. But for the public, we take what the government gives us.
Sorry, so can I just, all right, thanks. Can I just leverage what he asked,
Yes.
right? So in relation to what you've just described, so what payment mechanisms are you using for your accredited providers, right? And I think linked to that, is there a thinking around utilizing the fund's strategic purchasing function to influence the distribution of your providers? Because if I look at the list, the slide that you showed,
Yeah.
it looks like you have a huge concentration of providers that are contracted in urban areas.
Absolutely.
But knowing the Zambian context, there probably is need that is not met as a result of that picture. Is there any thinking around using a strategic purchasing function to?
Absolutely. So currently, so when we started the scheme, we accredited based on the current distribution of facilities. And the facilities are concentrated along the line of rail in the urban areas. So we had to work with that. But now we have what we call needs-based accreditation, where we want to drive supply to areas where there's need, but you have no supply. So we pause accreditation. So we got all the public healthcare providers as given. We got most of the private sector along the line of rail, but obviously the issue of equity comes in. So what we have done now is to conduct what we call needs-based accreditation based on population distribution. And we're calling accreditation in areas that are underserved. So what we're likely to see is more private sector participation in areas where they would otherwise not be there, because you're providing the financial incentive and guarantee of accreditation once you set up in that particular area to service the population. So I think in the next 3 to 5 years, we might see a lot of private sector players going to areas where they would have otherwise not gone to. Oh yeah, sure. So we have a combination of fee for service, DRGs and capitation.
Thank you, Herriman. I think we need to move on to the next presentation. We'll get
Thank
back
you.
to, there was a question online about enrollment, but I think we can take that as we go through the panel. Thank you, Herriman. So we see mushrooming of private providers in the insurance. That indicates that they should be happy, I think. There's also, Herriman says that clients are generally maybe happy, at least with some aspects of the insurance. But is that really the case? We're going to turn to Warren here, who's actually studied it. So over to you, Warren.
All right, thank you so much. All right, so we collected impressions from the public as well as private accredited providers just to ascertain the feel on the implementation process itself. So Herriman has spoken from the fund perspective, and this is from the public perspective. And practically, to derive these impressions, we use qualitative content analysis of their impressions. So we use social media analysis as well as actual interviews with private providers. And these are some of the cuts, and we'll dive deep into them just to ascertain their impressions. All right, so this is how the presentation will be like. And so in the social media analysis, this was something exciting for me. We had a lot of conversations in 2022 that has been cut off, but 2022 had a lot of impressions. So the fund initially began in 2019. Access began in February of 2020. There was little conversation about the National Health Insurance implementation in 2020. But I think when experiences began evolving in 2022, we saw a lot of conversations around it. And this has even increased now. But the assessment in 2023, we only did it up to February. So we looked at social media analysis from February of 2020 to February of 2023. But that's an impression now. Great, so this evidence comes through to almost 6 million people in terms of total Twitter coverage conversation. So it was very exciting, I think, diving deep into all this. All right, so what are the impressions when it comes to revenue raising? So when it comes to member being eligible to be part of the National Health Insurance Scheme, what we've seen is that over time, the public is increasingly understanding that everyone else could actually join the scheme. This previously was not the case, but down until February of 2023, there's still members of the public that do not know how they can get to be members of the National Health Insurance Scheme. So there are challenges to do with eligibility in that. And also, which has been quite exciting, is the inclusion of the elderly as free access members to the scheme. And this is a huge kudos that the public has given to the authority for providing services for free for the elderly. All right, but there are still challenges in getting signed up, more or less restrictive challenges. So you noticed, I think from the previous presentation, that there's a large number of principal members, but there's a lower number of dependents. Ideally, on average in Zambia, you have one principal member having 5 dependents, but the statistics are not showing the case. So there are challenges in getting dependents on the scheme. So largely you just have the covered principal member and not dependents. Great, so people are motivated to join the fund, primarily because of financial risk protection. And we found that to be the major reason in the coding that we did. Adverse selection seems to be inevitable, especially in the informal sector. So you join this scheme, you have to pay a 4 months waiting period, but you can pay it upfront immediately and begin accessing the service. So if I'm going to spend a 20,000 common currency dollars on a good, I would rather pay the 4 months waiting period and join the scheme and then later on stop paying. So it is something that the public was talking through, and a lot more people from the public are actually having it done. So the improvement there is obviously to improve compliance to this particular process. All right, so contributions, there's a common understanding that, yes, you only consume services within the scheme if you actually pay for them. So people know you have to pay. The challenge is making those payments, having the payments modalities to sustained payment modalities. There are questions that the public are asking. So for example, especially in the formal sector, you only have money once after a period of time. So can you pay upfront payments? And currently the scheme does not allow for that. I should be guided, but ideally the public doesn't seem that is actually happening. Also, yeah, paying once a year if you can, and if you can contribute a larger lump sum. All right. There are challenges with communication, and this was a prevalent concern from the public. They do not know how to register. If they register, it's impossible for them to get feedback, even advice notices on their contributions when they fall due and things like that. These are some of the costs that we obtained. 1% of my pay goes to NEMA, but I've never even for a moment received an SMS from them. So the one to be in touch with where the money is actually going. Okay, so the provider accreditation, a lot has been discussed already. There are challenges, and this the public did cry out on. There are challenges with the distribution of providers. The majority of them, I think you saw from the previous slides, they're in urban areas, and that creates a challenge. So already the existing inequities in access to care from rural areas are even more increased as a consequence of how the accreditation process is done. To do with that, so ideally the public is perceived to have lower quality. So there's a huge demand going through to the private accredited facilities. But what is happening now, even the quality in those private accredited facilities has really gone down. And these private facilities are now creating what they term as NEMA wards, NEMA sections, where only NEMA accredited, NEMA contributing members are serviced. So you have some form of differentiated care still in these facilities. So the attitudes has really also just changed. Great, and add to that also, there are some accredited facilities, there are layers apparently with private facilities also. They're the top layer that do not want to be a part of the scheme because maybe the tariffs are not really representative of the cost reflectiveness of the service provision. So as a consequence, you only have some private providers that are already strained, and now the quality of servicing is just becoming poor. Great. When it comes to approaches of accreditation, so initially, yes, there was accreditation across based on need, and now that is improving towards geography. But the concern now is, and this quote did come through from our provider, an accredited private provider. So ideally, they're looking at areas as to how accreditation can actually be done based on services. So you still have people living, you still have private providers in urban areas who are not accredited, but they provide very unique services that members need. So instead of getting the geography, but accreditation could actually still be done within those spaces and accredited facilities where there's actual need for services, like CT scans, for instance. Okay, so the benefits package, very generous package. NEMA oftentimes perceived as a service provider. I think that notion will obviously have to be changed with communication. There's also a call for innovation on the package itself. So there are some conditions, rare conditions, that are not part of the package. So consumers have to incur out of pocket to actually pay for them. So there are concerns to say, can we have a benefits package that is more reflective? If it's not, then there should be a cohort of consumers who could actually be allowed to consume particular services. And I think this is happening in certain countries where consumers can be allowed to consume services which are not really contained in the package in itself. All right, so even the development process for the benefits package, the public has been asking for evidence. What is the evidence as to why certain conditions are left out, which ones are included? Has this been driven by participatory approaches? And they would want to see more of that. Okay, so there's reported reduced quality in facilities, this we have seen. And yeah, consumption also, the greater portion, I think that has been cut out, but the greater portion of consumption, we saw, we coded a lot more of what people are consuming, and it was coming through from consuming corrective lenses, which could also be a challenge, because that could also be a burden to the scheme because it's quite expensive and a lot more people feel fancy to just have lenses on. Okay, so NEMA implements the scheme by having help desks within public facilities. But what was seen from the private providers who are secondary recipients to clients coming through from public providers is that these help desks are not really doing their work. So they'll send through prescriptions that will end up in private providers' hands that do not have authorization codes, that do not have numbers with them, which proves a challenge when it comes to claims process. So the public was asking for more training to this particular NEMA help desks. All right, so provider mechanism in the claims process, and a lot of this input came through from our assessment of the private providers. So they're asking for engagements in improving how claims processes are done for inpatients. So an inpatient, apparently, ideally, you have to have your biometric reading if you come through to access facilities. But for an inpatient, that is not possible. And for a provider, it means they have to go a lengthier route to ensure that they claim for an inpatient. And it even takes longer for them to actually get paid for it. So they were asking for this to actually be improved. Also, communication protocols. NIMA is innovating quickly, which is super exciting, but those innovations are also not heavily being communicated to providers. So as a consequence, you get your rejections without actually knowing that a protocol was implemented for the claim that you're processing. So reducing paper-based claims, that has been discussed. And also, because of the changes of technology, I think they're migrating from different technologies. That has caused a lot of data to be lost. So a client goes through health seeking and they find that their gender has been changed, their age has been changed, they cannot access care, so they have to wait until that has been updated. Even the claims process is more challenging because when you submit claims based on this, then you're told, wow, your claim cannot be processed because the gender for this person cannot receive this particular care in itself. So this primarily coming through from private providers, the ask was to improve the data processes because it does affect their claims. So a claim which should arrive within 4 weeks takes longer because of these rejections. All right, and when it comes to tariffs, there was a call for increased participation of stakeholders using evidence, which should be guided by cost reflectiveness of the tariffs themselves. Great, so when it comes to the overall governance for the National Health Insurance Scheme, within NIMA in itself, the recommendations were improving internal trainings. So private providers will communicate to different people within the team and different people provide different answers because protocols are consistently changing. So not having a uniform voice does challenge access to services, but also the claims processes for providers. The data, we talked about financial feasibility assessments, actuarial evaluations. The public is asking for this data. They want to be a part of the decision-making processes. If we're talking about increasing the contribution rate, they want to know the data. So more relays of information for the scheme. Member education, a lot more people do not know how to register into the scheme. They do not know how to contribute, where to seek services or what services they allow to the benefits package. So there should be increased education, and this was a call from the public. Availability of help from NIMA. So apparently there's NIMA works is trying to be guided. So, but ideally, the private sector was calling for increased availability of staff, even over the weekends and in the evening, because clients always come through at 1 in the morning and they'll need to access care. But if you're waiting for authorization, you have to wait until someone else comes through to provide it, and diseases do not wait. Okay, so NIMA has got provincial offices within provinces, which is really excellent, but providers thought maybe there should be a lot more decentralization of power. Currently, they have to send claims to Lusaka, for example, which is where the headquarters is, but a lot more communication could actually be done within the provincial centers and reduce all this red tape, which also limits how they access information or how they undertake their claims processes. All right, when it comes to general interaction between NIMA and government structures, and this could be discussed, I think, from the Ministry of Health's perspective, that when a consumer accesses care from a public facility, they can choose to either show their membership to the fund or not. So they can consume free services and go through the referral system, or show that they're a member of the fund and then receive services through that. So that protocol in itself has to be made a lot more clear through the healthcare seeking process. All right, there was also consent to improve allocative efficiency on public grants to public facilities. And this is in relation to improving facility readiness to provide the benefits package that NEMA provides. As noted earlier, there's a perceived low quality in public facilities. So there should be better use of those resources to make the facilities much ready to provide the benefits package. Great. I think stakeholders, there's more consent that stakeholders, the public, private providers must be included in the decision-making processes so that there's a collective action on whatever protocols are developed. All right, so if you have to take anything from this conversation, it's this. I know it's lunchtime, but so ideally eat education to members. There's a greater need for the general public to be educated about the services that NEMA provides, the contributions and how to access care. There's a greater need for accredited facilities to be ready to provide their services, especially for the public facilities. And now even the private sector where quality is actually deteriorating or reducing. Technology use also, use of mobile phones, for example, for contributions, access to the NEMA portal. There's an ask from the public that this could be better improved so that everyone else would actually have access. All right.
Thank you, Warren. Round of applause. So just a small question. Back into 2020, you were part of work that we did on exploring perceptions of private provider at the onset of NEMA. They were very worried about reimbursement rates. They were very worried about timely payments. Is that worry still there?
No, I think I removed one of the quotes. The private sector is very excited. There's almost a guarantee that once a member consumes services, they'll actually be paid. So a lot more. And a lot of others that we interviewed that joined just a year ago were motivated by having seen payments come through to their partners. So there's a huge motivation for the private sector to join the National Health Insurance
Almost
Scheme.
too excited, maybe.
Yeah.
Thank you again.
All
Thanks. All right. In the interest of time, I'm actually not going to bring up my presentation, but basically I just wanted to say a few words about the fact that we're trying then to evaluate the impact of this. And we're setting out over the coming year, we as in University of Zambia, Lund University, University of KwaZulu-Natal, in collaboration with the Ministry of Health, with NEMA, Central Statistics Office, on a huge effort to try to redo a survey that was done 10 years ago called the Zambia Household Health Utilization Survey. We're at the planning stage of this, a huge undertaking of going out to about 12,000 households to look at then healthcare utilization and healthcare spending, to be able then to see what did we see in before the introduction of NEMA and now after, and in particular then looking at these aspects of access to services and financial protection. So we're trying to collect the detailed data on that. And in Zambia, out of pocket is actually not that high in terms of share of total health expenditure. And if we look at the data from the World Bank, I think it's down to 10%. But then, we're not really sure we can trust the data to actually be that low. But we also know that much of the drivers of out of pocket are things that are not necessarily healthcare related. I mean, healthcare related expenses, but not healthcare expenses. Stuff like transport, for example, big driver. Having to source drugs, diagnostics outside the facility because it's not available. So there are other drivers. So even though we have NEMA covering things, will we actually see an impact on incidence of catastrophic health expenditure? Maybe not as clear, but we're just going to spend the coming 12 months trying to figure it out in more detail. With that said, we're not going to dwell longer on presentations. I want to get some competent reflections on what we heard this morning. And we invited 4 distinguished people to join us for a small panel where they reflect on this. And I would like to invite them all up on stage. First, I would like to Director Planning from Ministry of Health, Mrs. Madrin Mbuta. We have the Director General from NEMA, Michael Njapau. And we have Chitaro from UNSA. And finally, we have Owen Brady from CHAI. Could you all join us up here? And we give them a round of applause to welcome them. And the room has filled up since I last stood up, I realized. Great to see so many people here. So we are going to start off with asking the ministry and Madrin, as in your role as Director Planning, Would you mind sharing a few reflections on these first few years of NIMA and what is it meant to Zambia and the ministry? You can use the mic there.
Thank you very much, and good afternoon, everyone. Good afternoon. Thank you. I think in my little time with the Ministry of Health, I've seen that indeed NIMA has contributed to the well-being of the health people in Zambia. Let me start by giving advantages of any health insurance in a given country. What are the advantages? One of them is improved access to healthcare. And of course, with NIMA having been established in Zambia in 2018 and being implemented in 2019, we've seen that indeed it has provided financial protection and ensure that there's a broader population coverage in terms of accessing essential healthcare services, regardless of their ability to pay. This is because the people are able to access both the private health facilities as well as the private health facilities, unlike the way it used to be previously before the introduction of NIMA. Secondly, we have seen that indeed there's enhanced health outcomes because of increased access to health insurance services that can lead to improved health outcomes, early detection of diseases, and also timely treatment, resulting in better overall population health. So this has been our experience. Of course, I should say that you know, I'm doing a comparative analysis of how it used to be and how the situation is as at now. Another advantage that we can visibly see is that there's systems, healthcare systems strengthening because the enablers to provide quality health services have been kind of addressed relatively compared to the way it used to be in the past. Here I'm talking about the availability of, for instance, the human resource, modern equipment, the medicines, and also health information and infrastructure in hospitals in comparative terms. Yeah, but of course, when you look at contributions themselves, we are able to see that the contributions are mainly coming from the 17% of people that are in the informal sector, as opposed to, you know, the other more than 80% population, which is mostly in rural places. And of course, when you look at why these people are not able to contribute, mostly you can say that they lack information. And also some of them are not able to actually contribute because they are impoverished. They are poverty stricken, and some of them are even under the social cash transfer programs. So they're not able to easily make contributions to such facilities. Yeah, I think those are my reflections so far. Thank you.
Thank you so much. Can I ask a follow-up before you hand over the mic? Herriman was alluding to the fact that, you know, even though NIMA is not a service provider, they get taken for being the service provider and then almost get the blame when things are not working. An interesting feature of NIMA is that it's not under your ministry. It's actually under the Ministry of Labor. Yes. Yeah. So if NIMA is not working, are you getting blamed as you're the Ministry of Health, even though it's not your agency?
Well, we get blamed because we are government. We get blamed because we are government. You know, as government, we are supposed to work together. But of course, during the establishment of NIMA, NIMA was established under Ministry of Health. But because of the fact that there was an understanding that its mandate covers more of social protection, that's when it was moved to Ministry of Labor. But really, when you look at the provision of health insurance and also social protection, there are overlaps. And really, we still take the blame in some cases because we are government and we are supposed to ensure that we respond to the expectations of the people that we are serving.
Thank you. So I think we pass the mic on to Director General of NIMA, Michael Japao. Please, what are your reflections? We should add, you're relatively new on the job, so we shouldn't give you too hard a time.
Okay, no, that's fine. Good morning, everybody, and greetings. First of all, thank you for the opportunity to be able to talk about the universal health care in our country, in Zambia, and for the role that NIMA is playing to be able to achieve that goal. So my first reflections are that it is a good thing that NIMA was created, actually, irrespective of the challenges we face. But the plan or the goal to achieve universal health care is something that NIMA should drive, and that's what we are doing. Though, of course, currently we are faced with, so we have a couple of good things, the milestones that were provided in the presentations in terms of what we have done. And coupled with that is the challenges that come through. Largely, if you look at it from an overview, most of the challenges are really what you would call teething problems, because we're a young institution. And while the goal was good, the fact that we've just been operating for a few years means that there'll be certain learning curve things that come by the very fact that we started operating in 2020. So some of the things we are grappling with currently are, of course, what you had, the challenges that come with the solvency that are going on the fund, and for various reasons. Mainly among those reasons are the contributions which are not commensurate to the benefit package. So we have to look at that. We have to look at the benefit package going forward. We have to look at the contributions going forward. Number one, currently that's number one. Number two, currently the fund is largely financed by the formal sector. And yet, if you look at our claims, the claims are more on the informal sector. And that's also affected by two major things, if not three. One, in the informal sector, the disease burden, the morbidity rates for the older people is much higher than the working class. And obviously, generally, when people are working, their health is better than those who are not working for obvious reasons. You eat well, you're in a good environment, so your health is better than the people in the informal sector. And so, and yet you'll find the people who are actually paying are those that are okay, and then those that are accessing the service are those that are not, that are on the other side of the sector. And then we have this generous package, which provides everything without any cap. So those are the challenges we're looking at. The benefit package literally offers everything, and it's not commensurate with the income or the contributions that are paid. I think that came out clearly in the presentation. Some of the things we are also facing are what I would term unscrupulous, or maybe what's the best term? So there is a segment of some of the private health providers who don't look at the service, they look at their benefit. And so when a patient walks in a private healthcare hospital, or pharmacy, especially the hospital, you have a situation, somebody has a cough, but then there's subscription of services, which is largely driven by getting money from NIMA. And so it's a bad attitude. Okay, so this person just has a cough, but then they'll, because they know this is from NIMA, so they'll oversubscribe the services to this patient, which when you look at it critically, there was no need, but it's all driven by getting money from NIMA because they know NIMA is going to pay. So there will be services which you would maybe subscribe to a very ill patient. For example, the diagnostic process would then be expanded simply because then you are going to get money from NIMA. And so we have to deal with that. And then we have our own inherent bad attitude as well as citizens, especially in the informal sector, where people don't subscribe to the scheme when they are well. They only want to get to the scheme when they are sick. And after accessing the medication, again, step away. So when you look at the big port, you are then first with the scheme is currently funded by under 20% of the people. That is of the formal sector. And yet the claims portfolio is expended by the 80%. And in that 80%, it's the informal sector. So obviously, those are some of the challenges we face. And those are some of the things we'll be looking at going forward. Like I said, it's a good thing that NIMA has been created, but from here henceforth going forward, we need to put in the proper mechanics that can help sustain the scheme. Obviously, we have to find ways of financing the people that can't finance themselves. There's no question about that. They will always be there. We have to find ways to meet the needs of some of the people that consider our service to be too basic. That's also another challenge. How are we going to provide for the executives, for the permanent secretaries, for the professors? Their needs are different from the fisherman in the field, in the bush. So there are all those challenges we have to deal with. And critical to that, we also have to deal with the system, the technology aspect. And thanks you, Warren did bring that up. We need to get to a stage where our systems work. So half the time, some of our clients go to the hospital, the system is down, and they'll be told the system is down. We have to get to the bottom of what causes this, because in the end, it does affect the service delivery. The Minister of Health will be blamed for what NIMA does. There's no question about that. And then NIMA gets blamed for what Minister of Health does also. So we understand that relationship. But as a government entity and as government themselves, we understand our role very well. But I think we're glad that we will be there to probably NIMA in the next 3-5 years will not face the kind of challenges that we are facing, because like I said, we're a young institution, and just by virtue of that, we are probably in a learning cave.
Thank you, Director. It seems like there's a tough discussion that needs to happen regarding the contribution levels. Are you up for that challenge, and when will you have that conversation?
Yeah, so first of all, you heard from our presentation that when the actuarial recommendations was actually that we should have started off at 5%. But for political compromises, we started off at 2%, which is 1% from the employer and 1% from the employee. So already we started off from a loss making, for example, if I have to say that. So this is something that we are engaging, both government. We have in our country what is called the Tripartite Council, and we're engaging with the Tripartite Council. The Tripartite Council is really the government, the workers' representatives, and the Federation of Employers. So we must all come to this table to appreciate the fact that if we go on the path that we are on, this trajectory, this fund is not sustainable. And our currently the actuarial study that we have received has actually brought that much closer to our eyes, that if we are on this trajectory, we will be in a serious problem end of 2024, which is just a few months away. Why? Because of the same reasons that I said. So we have a package that provides everything to everybody at a cost which is not scientifically or economically calculated. And that is going to create a problem. So we have to deal with that. We are up to that. We have to deal with that critically if the fund is going to be sustainable.
Thank you.
But as we do that, we also have to look at the package. We obviously have to look at mechanisms like co-financing for certain things. We have to look at mechanisms like you can't have a package that is open-ended to financing everything for everybody for that kind of a price or the tariff that we receive. And so those are the things we'll be looking at.
Thank you so much.
Thank you.
I'm going to ask you to hand over the microphone to Chitalo. Chitalo is a researcher at the University of Zambia, and please share your reflections. I know you had a few slides as well.
Thank you, Jesper. Technological challenge. There we go. Okay, so thanks again. So I'm here to just present a couple of points reflecting on the implementation of the National Health Insurance Scheme in Zambia. So I think the first point we're looking at is coverage of the poor and vulnerable. So we know that just the first step to set up the NEMA shows the government commitment to trying to lessen the financial burden on individuals. So we know that even in other low middle income countries where we have concessions or provisions, such as we have in Zambia, where we have the poor and vulnerable being covered by the government, and those who are over 65 and mentally and physically disabled are covered by the government, we still see that there's low coverage, even amongst the poor and vulnerable, averaging about 36%. So what we would like to understand or further unpack in our context is to what extent actually are we covering the poor and vulnerable populations. We have heard that in terms of accreditation of health providers, we see that this is skewed towards the urban provinces. And so how that then enhances or worsens the lack of access for the poor and vulnerable is something critical that we need to look at as NEMA. Also, issues around the administrative enrollment processes. Are they simple enough? Are they facilitating access for enrollment to the scheme, even amongst the poor and vulnerable? So we know that one of the mechanisms for enrollment for the poor is through the social welfare scheme, which in itself has inherent weaknesses. So we know that even through that mechanism, we're excluding or we're leaving out some people. So how do we deal with those issues? Is the automatic screening where you identify and put them on the scheme, is that working? How is it working? Regarding the communication mechanisms that we're using to enhance awareness, how are those working? How are those mechanisms working? Are we able to access the people in the rural areas? Are we engaging with the community leaders as sources of trying to ensure that people are aware and know of the National Health Insurance Scheme? As we go forward, we need to think about using evidence-based knowledge. We need to engage. It's important for us to understand what are the existing best practices to effectively expand coverage amongst the poor and the vulnerable. And ideas such as collaborating with research institutions to try and establish or determine the contribution of the scheme in reducing inequalities in health insurance access between the rich and poor over time could be useful avenues for generating evidence. So the other issue relates to the informal sector. So as we have heard, the informal sector constitutes a big, the large majority of the Zambian working population. So with that, we need then their behavior or their experiences. So we know that people's experiences with the health system shapes their decisions or what they do. And so how this group of people behave is actually very important for our system. So we know that in a recent study that was done in Zambia, we know that the confidence in the health system among the informal sector was strongly linked to enrollment in the private health sector in terms of accessing services in the private, amongst the private providers, because of the subjective perception that the quality of care in the private sector was better. And so as we have heard, this has led to a shifting of demand in service use from the public to private, and that has implications on the costs for the scheme. And then we also see, and I think more anecdotally, people shifting from using maybe lower level services within the public sector and using the higher level public facilities where they can access NIMA. So we see that shift. Also, it has cost implications to a lower extent, but that's something also we need to think through. And so we've talked about also issues around encouraging private sector participation. So how then do we make sure that we engage this private sector to be partners? We see that there's this provider-induced demand. How do we engage the private sector to ensure that they are partners, they come on board and understand our objective and potentially work together? How do we do that? So we've talked about the issue of leveraging digital technologies to ensure that we enhance the administrative processes. So another interesting issue, I think, which I noted on social media was the messaging. So we probably need to understand whether these messages that we put out on social media are evidence-based. So most recently, about a couple of months ago, you'd see messages on the NIMA website showing personal experiences of beneficiaries, and you would see the name of private health providers there. So for me, it was quite startling because it seemed like you were promoting the use of health services with the private providers. So that was consistently kept coming up, but I noticed in the past few weeks that has changed. So we need to make sure that these messages that we put out are evidence-based so that we don't compromise our system. So, and also another important issue is regarding the issue of quality of care. How then we know that NIMA is not the provider of services, but how do we engage now with the providers to ensure that the quality of care is improved across all facility levels? Because we see that this perceived subjective quality of care in the private sector is affecting the system. So we need to engage and see how do we then facilitate this, or how do we collaborate to ensure that we improve quality of care. And finally, this is, I think, the common theme that has been running around, the fact that we need evidence. We need to engage with researchers, with international and local partnerships to ensure that we generate evidence that can inform the decisions that we make going forward. The director has made a very scary statement about the status of of our fund in the next couple of months, and that calls for us making the right decisions using evidence. We need to engage researchers. We need to ensure that the decisions we make are based on robust evidence. I think those are my few reflections.
Thank you so much. We'll hand over to our final commentator, who is Owen Brady. Owen, you worked with CHAI, the Clinton Health Access Initiative, in several countries in the region following health financing reforms. What are your reflections hearing the presentations?
Sure, thanks, Jesper. And thank you for the presentations. I found them very interesting and a nice variety, from the academic systematic review to the programmatic report to more than 6 million tweets. So it was a nice kind of overview. But I want to pick more or less Herriman's presentation to focus on and just make 3 quick points. I think 2 are around equity and 1 is around capacity. I think several people have alluded to the first equity issue already, which is in terms of covering the poor and vulnerable. You know, this has been studied. I think there's quite a body of literature around formal sector, labor tax-based schemes, and just the scope of their ability to provide universal coverage for vulnerable populations. The numbers are difficult to add up, and so you find that introducing a scheme starting with the formal sector, you saw all the expectations from Warren's presentation. It tends to increase focus on that sector to provide the services. We had NEMA awards, which I think there was gasps in the audience. I think that's been seen before, in Latin America and elsewhere in the world. So I think it's useful to note that the more successful efforts in this regard have drawn on general taxation and a broader funding base. So I think that point has been touched on. I think nobody really has mentioned engagement. Political will was referred to, obviously huge, but engagement with ministries of finance and how they think about this scheme in the health sector generally. I'm curious if those conversations are happening, because this is essentially creating another pool in an already fragmented system, and could divert resources from elsewhere in health. That brings me on to my second equity point, which is around how the rest of health is paid for. So you still have there's the starting point was primary healthcare is already taken care of. That's free, no problem. Is it no problem? I think it's paid through an input-based system largely. Is everybody receiving the primary healthcare? I'm not going to go into that, but that conversation with finance, they may see NEMA as part of providing health services to the population. And, those resources are fungible. They can be, is it a zero-sum game between the rest of the health sector and primary healthcare in particular, and diverting more resources to NEMA if you do have that conversation? So I think it's an important consideration when you start off with the principle of equity as one of your first 6 or 7 bullets. So I'll make one more point, and it's a little bit left of field. The session before this was on kind of long-term capacity that's needed to and focusing on health economics, because we all know how important health economists are. But I think looking at what an institution like NEMA, if it grows to be the best version of itself, what it needs, in terms of the range of capacities from, of course, health economists, but accountants, managers, actuaries. It was also mentioned, one private scheme in South Africa here has, I'm not going to get these numbers right, but I think it's 40 actuaries covering a 6 million life scheme. You've enrolled 3 million, so I assume there's already 20 actuaries in there. No, but so obviously you don't want to replicate the private sector schemes in South Africa, but looking down the line and saying what's needed in terms of solvency and sustainability, actuarial is just one. But I think you could look at a range of the quantity of data that comes in from once you clinical coding. Once that massive data comes in, you're going to need to use it to remain solvent and sustainable. Are the people there? Is there a pipeline of people? UNZA is very engaged in this conversation. It's great to see, and I think there is expertise in the region. But are we really thinking about that pipeline of capacity as well? So those are my main points. I had some minor clarifications with Warren and Joseph. I think
look at the errata list later. But thank you, Owen. I'm going to look out to the room because I also, do that. And in the meantime, start waving your hands if you're interested in contributing to this. So hand over the mic to Michael, and then we can see we had. Okay, great.
So I'll start with the last one, actuarial support and ensuring that we have evidence and data. So currently we have a wonderful support coming from the EU, just like as an institution. Most of the data information that you saw in that presentation is based on a proper study, which has been provided to us by the International Labour Organization. And they've provided us a good actuarial comprehensive study that provides us with what's obtaining on the ground and a better focus of what the scheme should be in the next few years. So the presentation is really based on evidence that has been started and properly checked by actuaries. Yeah, obviously, Brady has got a good point, but NIMA is not at that stage yet to have in-house actuaries, but I'm sure with time, that is the way it would go. We don't take it for granted that the support from ILO is permanent. It is basically just to support us, get the scheme off the ground and get the scheme properly established, maybe and then graduate that relationship to some level where we'll be able to provide our own study, our own actuarial assessments within in-house. Accreditation. So within ourselves, we more or less resolved that accreditation for hospitals will be driven in maybe 3 categories. The first category will really be to drive towards more public sector. Public sector will be our first, public and faith-based. So in our country, we have a lot of faith-based large hospitals that are basically just some of them, most of them outside the line of rail. Would like to ensure that the accreditation is driven more in the public sector hospitals, that's the government hospitals, and the faith-based hospitals. They are run by the Salvation Army Church. They're run by the Christian missions and mainline churches, by the evangelical churches, the Christian Council, and all that. They are huge hospitals that would like to see that the accreditation is driven in that. And second, facilities that are in the rural area, because like you heard in our presentation, so we have a lot of formal employees that are in rural areas, the teachers, the policemen, and so on. So how do we cater for those? So we need to accredit a lot of rural institutions as well to come on board. Whether they'll be private or public, we'll try and see that that is done. And so the private, commercial, urban will probably be listed on our, going forward, on our listing, because currently that's an area which looks like already being fully met.
I'm interested in also having time to allow some participants in.
So the drivers for the private hospital is not NIMA. It is the individual person on the street. And I think we also need to deal with that. So when a person is unwell, the ordinary person in Lusaka or Ndola wants to go to a private hospital, they would spend a few minutes, see a doctor and move away. We alluded to that in terms of public, in terms of quality of sales, of health delivery. So we then get this back of claims coming more from the private, because our person there feels by going to UTH, they'll be there. Our client feels by going to UTH or Manawasa Hospital, they'll be there for hours. So they would rather take a quick service from a private provider. We have to deal with that. And there are a lot of reasons for that. Yeah, thanks.
Yes, there was a concern about the engagement with the communities about NIMA, especially in rural areas, and also the type of messages that we put across. I wanted to say that I think this is we should realize to start with that NIMA is still a baby of 4 to 5 years old. And this baby has not yet been known. And how do we get this baby to be known? Of course, I'm talking about rural communities. I think there's need for us to take a holistic approach where we are going to talk about the benefits of being contributors to a health scheme like NIMA. So we should ensure that these messages get to the people on the ground using different channels. We can make use of traditional leaders, for instance, because once a traditional leader speaks to the people will easily get influenced. We have to use the churches we have to use even the non-governmental organizations, the civil society organizations, so that they can kind of package the messages that are appropriate to the communities, the messages that are going to be well understood, so that in turn, these communities can think of contributing to the scheme because it's for their own benefit rather than the way it's happening now. Thank you.
Thank you. Now I'm going to move over. We had a few hands. We had Peter and.
Thank you so much. Very interesting conversations. What I just want to pick up the aspect of sustainability. So you said that there was an actual assessment on the fair contribution that was 5%. Has there been a similar assessment of what is actually fair contribution from the informal sector? That's one question. So, and have you used that? So when you go to the informal sector, and of course, in terms of targeting, you're already going to those that are already on the social protection scheme. So whoever is subsidizing those people, are they paying the actually fair price? That's one question. So are you able then, because I'm thinking you cannot have it and eat it at the same time. So if you have to maintain sustainability of this scheme, and you're saying only 20% are paying, then why are you continuing expanding to those that are not paying if you still want to have this scheme going on for some time? Are you considering stopping, for example, the expansion and all those things? Maybe let me stop there.
There were 2 or 3 questions in that, but I'm gonna collect a couple of more before we hand over. You don't have to post a question to the panel. It could also be to the presenters, and maybe.
So I just want to thank you so much. Just want to chime in on what about sustainability. You alluded to that you pay the private service providers higher reimbursements than the public. So my question is it by default or design that I'm comparing also to Kenya, where the private is paid higher than the public health system, yet the inputs are the same. If, for example, a mother comes to a public health facility for a normal delivery, the midwife is the same, the oxytocin is the same, everything is the same as that what will be used in the private sector. So probably you would want to share and tell us why is it that you are paying more to the private from an actuarial perspective? And then 2, wouldn't it be better to even pay more to the public so that because of increased access to care at the rural facilities, for example, and if they have autonomy, it means that they'll have, they're able to buy medicines or HPT, so that now we have quality services in the private sector. Because you have more facilities, it means you increase coverage. So please share with us why you're paying more to the private and not to the public. And maybe that is why you have more private facilities mushrooming. Yeah.
I'll give Herriman and the director a second to ponder. I'll gather a third question, then we'll say stop for now.
Okay, so again, the question is on sustainability. I think from what has been presented, I do not see that the scheme being sustainable. I'm a Zambian, but I have to be honest. First of all, you're talking of 17% being the membership, right? Those are people paying. But if you look at your effective coverage in terms of beneficiaries, I think it was about 800, about 5%. And then you are saying that it was supposed to be 2% contribution. It is set at 5%. And we know that contributory schemes often don't survive. You don't have any other ways of looking for additional revenues. Further, you provide more services through the private sector, which are expensive. My wife just had a procedure where the cost in the private was about $8,000 compared to the public where it's about $500. So, I mean, I'm just giving an example. I know your scheme is not full cost recovery, but those are some of the costs. Then, like my colleagues from Kenya was saying, most of the people in Zambia access public facilities. Yet, we are now giving more money to the private because there's a profit motive there. And what does that mean? But then you want to expand it and say, well, we're going to cover more people in the rural areas who are not currently accessing through the public. So why don't you then just provide money to the public sector? The last point is that the scheme is now, you have two funding pools, like I think someone mentioned earlier. Money coming from the tax system already, and also from insurance. How do you hope the government to increase funding to the scheme when the road is saturated? So I think there are a lot of issues you need really to sit down on this, because honestly, I don't see it being sustainable. You need to think about it critically.
Yeah, sorry, Matt Jowett, WSU. Just a quick one on the sustainability. I mean, I don't know all the details in Zambia, but there are things that we know, like don't have open-ended fee for service, right? So whether that's going on in the private sector, we know that will drive up costs. Introduce some kind of HTA, right? So on things like treating diabetes, like Thais did, use the most cost-effective first, and if that doesn't work, go. So be more, be a strategic purchaser. But just a final point is thinking about sustainability. A lot of the solutions to the sustainability lie outside the health insurance scheme, right? And you have to have a system level perspective on sustainability, right? So what you see in a lot of these schemes, and I think it was mentioned earlier, is growth in use of high cost services. Now, it's not to say, let's argue that they are all needed services. That's fine. But you've got to then look at the rest of the health system where, let's say 95% of public spending is taking place. Let's not forget that, right? Now, if they are really good at prevention, early detection, early treatment, that would solve part of the problems that you're talking about. So you have to have that system perspective, or else this discussion will sort of trickle on.
Thank you. Great questions. They're all directed to Nima, I think. Should I give the mic to Herriman? Or... Yeah.
Thank you. I'd like to agree with the last statement. I think we all agree that we don't really run healthcare systems. We run sickness systems because our healthcare system interacts with people when they are sick. There is underinvestment in primary healthcare and preventive health, hence the rise in demand for curative services. So basically we come from sickness systems, and our fund is basically a sickness fund. And until we address primary healthcare and preventive health, that will continue to be the crisis. So we need to invest more in preventive health. Now, with regards to the sustainability question, so if you look at the solvency equation, it's just revenue and expenditure. The expenditure side is the benefit package. We all agree that we have the most generous benefit package given the revenue stream. So one of the sustainability ways is to look at the benefit package. Do we have to cover what we have currently included in the package? Or can we remove some of these and take them to the Ministry of Health so that they can be dealt with at the primary and preventive healthcare level? And that's where we're heading to. The other side is the revenue side. Right? We agree that the 2% of basic income is certainly the lowest that we can get. So we have to work on raising the contributory rate, which is a political issue as well. But also importantly, not just the rate, but the base on which you collect that. Now, what is the actually determined position, and does that account for the informal sector, as well as say the indigents, the poor and vulnerable? When you are running the actuarial assessment, you're looking at the revenue contributory rate irrespective of the source. So you arrive at the 4% irrespective of where that source is. The 4% assuming a certain level of wages given by the labor force survey. Now, for the informal sector, what we have estimated is that given the distribution of wages and the size of the informal sector, we need to agree on a flat rate. Currently, the informal sector contributes, like I said, based on the ability to pay, and we have an income assessment too. What we have seen is a behavior where people under-declare incomes, unexpectedly so, because they want to reduce their liabilities. But if you can arrive at a flat rate, which we have estimated, and ensure that there's 100% compliance based on certain measures, then we can at least achieve solvency. But ultimately, the solvency position is not on the revenue side. It is going to be on the expenditure side, and that is reviewing the benefit package. Is there anything else?
There was a question about pausing enrollment, I think. Yeah.
Yes, the differentiated prices between the public and private sector. So with the private sector, the price is cost reflective, the full cost of providing a service in the private sector. But for the public sector, we know that the government takes care of certain administrative and fixed costs. So they pay the wages, they pay the electricity bills, they pay all those things. So when we engage and arrive at the price, we discount what the government takes care of in the public sector. But for the private sector, we have to pay the full cost of a service. Hence the premium is, or the tariff is higher for the private sector than for the public sector. But also in terms of once you have arrived at, say, the actual cost of a particular service, there has to be a premium for profit. Because if you're just going to pay a cost reflective tariff, you're not providing any incentive for the private sector to come on board. So yes, we estimate the cost, which we run on our own to say, for example, a C-section in a public hospital is a C-section in the private. So you run the cost. Then based on that, you also add a premium for profit maximization, which is not more than 20% of what our cost estimate would be. That is to incentivize private sector participation. But like I said, in the end, we are not covering the full cost for the public because the government system takes care of that.
In addition to that, it is not very true that we pay so much difference between the private and the public. Actually, the tier 1 private hospitals don't want even to, I think you saw it in our presentation, or maybe from Warren's presentation, that there's some tier 1 hospitals that don't want to see NIMA patients because they feel the tariff is low. Yes, tier 1 hospitals and facilities want to avoid NIMA patients, and we're also trying to work at that because they feel that our tariff is low. And this is because we also don't want to contribute to the narrative and to the drive of pushing a lot of people in the private hospitals and take them from the public hospitals. There is a limit to which we can pay the private hospital. Beyond that, we can't. We would rather the patient, our first priority, our first goal is if we could, and we're going to be on that direction to drive the patients into the public hospital. And that's our goal.
Colleagues, we could go on all day, but we can't. There's another session at 14 hours. I know many people want to go to it. Now you know what the people look like. You've seen them. Continue asking the questions, continue interacting. We haven't even started the conference yet, so you'll be able to find these people, I hope. Thank you for attending. We will close here so we can all make it to the South Africa session if you want to go there. Thank you so much for your participation. Thanks for great questions. Special thanks to the panel. Round of applause.